Good evening to everyone present here with us today. This is Rion from IGCP, today's moderator. I would like to welcome all the viewers who have joined our platform for better exchange of knowledge that is going to be shared by our keynote speaker, Doctor, for today's session. With much pleasure and honor, I would like to welcome a very renowned doctor,
Good evening
Dr.
to everyone present
Unni
here with us
Krishnan
today.
Madatipat.
This is Rion from IGCP,
Sir
today's
is
moderator.
MBBS, MS,
I would like to
MCH,
welcome all the viewers who have joined our
FIACS,
platform for better
FBSI,
exchange of knowledge
consultant
that is going to
vascular
be shared
surgeon
by
at
our
SUT
keynote speaker
Hospital.
doctor for today's session.
With the help
With
of
much
Sir
pleasure
and
and
his
honor, I
wonderful
would like
insight,
to
we will
welcome
be
a
taking
very
a
renowned
close look on
doctor.
today's
Good evening
topic,
to everyone
which
present
is
here with us.
treatment
Rion
option
from
of
IGCP. Sir is
peripheral artery
MBBS,
disease.
MS. I would like to
Now,
welcome all the
without any
FIAS
further
join
delay, I
our
would like to
platform.
welcome Sir at
FIASI
our forum and
consultant
would like to hand
vascular
over the
surgeon
session
at
to him.
SUT
Over
Hospital
to
for
you, sir.
today's session.
Yeah.
Help us, sir.
Thank you, Sion. This is a good opportunity for me to spend some time with clarinet. And now, are you able to listen to me and see my slide?
Yes, sir.
Okay. So now I think all of us are aware and knowledgeable about lifestyle diseases. And the scientific term for this lifestyle disease is called atherosclerosis. Atherosclerosis means athero means the cholesterol deposition and the problems associated in our blood vessels, namely pure blood vessels of aorta and all the arteries which are originating from aorta. So this is very specific term, atherosclerosis. It involves the blood vessels. And the peripheral arterial disease, again, as you all know, it means the diseases which cause problems in our lower limbs and upper limb to some extent, because 95% of the problems are related to lower limbs. And that's because that's how we move from one place to the other. We can move around, we can do many things, we can run, we can travel, we can be there where we want. So it's very important to have the legs intact with us. There are three domains of atherosclerosis which is commonly involved in varying levels and difficulties. That means in the legs is number one because it's constantly being used. You need more blood supply when you walk and more, number one. Number two, the heart, the coronary vessels. And third, the carotid vessels. Those are the arteries giving rise to blood, providing blood to the brain activity. So these three are involved in many patients that we see in varying amounts. And whichever system has more compromise by reduced blood supply, they come to us presenting with those symptoms. But we always remember the other two domains or the other two facilities, the vascular beds, also may be involved because of atherosclerosis. Now I'll straight go to my presentation. Now, we all know the risk factors, what causes the disease process for us. These are the two risk factors, what we call non-modifiable risk factors, the gender, male gender, age of 60, 65. These are not modifiable at all. Why I say this? Most of the vascular diseases out of 10, if you take 8 or even 9, they are happening in male sex, and ladies and women are protected because of their hormonal status, that is the presence of estrogen. So maybe 55 years and more, the ladies also will have vascular diseases, but not to the same extent, because men folk are having this hormone level activities, muscular activities, right from maybe 15, 20 years and above that. So except for diabetic foot, it's almost equipoise for men and women, but otherwise it is basically more common, very much more common in males. Now, there are other causes, other risk factors. Smoking is a predominant problem. It releases the carbon monoxide and other gases. Then it makes the blood vessels constrict. It can produce damage to the blood vessel. It is called a panarteritis if it is smoking is involving the blood vessels. Then, of course, alcohol drinking. If it is just too much, it is going to lead to many problems, also including the arterial diseases. Diabetes also a cause, one of the risk factors. And hypertension next to smoking, that's very important cause of not only causing but propagating rapidly to form into difficult situations because of dysfunction of the appropriate organ. Then these two are commonly found, that is the obesity and hypercholesteremia, because of our dietary habits, which I think getting worse these days, not like we were eating, and our previous generation, they were more careful about the diet, and we consume a lot of oils, lot of fat, and then of course this physical inactivity is also rampant. So this is a bad combination of smoking, alcohol, obesity, physical inactivity in a man of 55 or 60 years and above. This is the basis for atherosclerosis and vascular problems, which we are going to deal with. Now, I mentioned this non-modifiable male gender and above 60. I cannot reiterate less than that. Then the other risk factors, and tobacco is dangerous, and hypertension needs to be treated. Now, atherosclerosis, as I mentioned, it is the fat deposition and cholesterol deposition, but there is non-atherosclerotic problems like in the case of arthritis, and then which again can be Takayasu arthritis, Berger's, giant cell, etc. And then other varying rare causes, which is also found for vascular surgeon to treat. Now, this picture shows the aorta and all its branches to brain, heart, lower limbs, kidneys. So it is basically involving the aorta, and aorta being a large vessel, 1.5 to 2.2 centimeter wide, the damage of cholesterol, which will get deposited in the wall, makes it balloon out. Rarely in the belly, this process can produce obstruction to iliac arteries and terminal aorta, meaning thereby aortoiliac disease. But rest of the places it will produce what is known as aortic aneurysm. Now, the problem with atherosclerosis, it's a generalized disease with segmental predilection, which means it happens right through the arterial and aortic tree, and the branch openings and their bifurcations are most involved in the disease process. This is a typical atherosclerotic plaque, which you can see that on your left, it is that yellow design tells you that the cholesterol, plenty of cholesterol there, a lot of inflammatory cells, and a very thin fibrous cap, we call it, which is covering, which is protruding into the lumen. In contradistinction, if you see on your right, it's called a fibrous plaque, very little of cholesterol and very little of inflammatory cells, the lymphocytes, monocytes, and all that, and very thick wall-like covering as the fibrous caps. So between these two, the dangerous thing is the vulnerable plaque, and on your left, there's a lot of inflammatory cells and cholesterol crystals, and very thin covering in contrast to the one on the right. And this is what happens. This is called a vulnerable plaque. The plaque can rupture, the plaque can have hemorrhage, and plaque can so these are the problems with the vulnerable plaque. And then this can produce embolization also. It ruptures, the cholesterol material comes out, it forms a clot, and that it can go to the brain, producing stroke. It can produce obstruction of the coronary arteries. It can also produce sudden obstruction of the lower limb, so that they have pain, they have rest pain, which I'll be coming to the details of the symptoms available. This is when there's an extensive area of the artery which is involved with the cholesterol deposition. And generally the clinical presentation, there are two varieties in this. Number one is acute lower limb ischemia because of embolism. It could be because of a cardiac cause. It can be mitral stenosis with atrial fibrillation and LA clot going out of the ventricle and into the aorta and distal tree. It can be because from the ascending aorta or arch, the atheromatous material can rapidly go into many vessels and produce acute problems. So this leads to an acute lower limb ischemia, causes which I have mentioned. The presentation is very abrupt, severe pain, and the patient may not be able to walk and move the limbs. Limb will be cold. It may be paralyzed. The muscles can be tense. And soon, after 24 hours, it becomes bluish. And then, if we are not managing this patient with an embolectomy and supportive therapy, their leg is in grave danger for losing, and which means, the life itself changes. Now, the next intermittent claudication, which means upon walking a distance of, say, half kilometer, the patient gets severe cramps in the calf muscle and thigh muscles, and he has to stay there, wait for 2-3 minutes, and then can again walk the same distance next time. To some extent early, this is now constant. But as time goes on, if this is not detected, if they don't go to a vascular surgeon in particular, and the risk factor control, stopping smoking, and the triple vascular therapy, we call it, all those things can reverse to some extent. And vascular medicine is very strong these days. It can avert the ongoing the atherosclerotic process by stabilizing, in addition to the risk factor which I mentioned just above. As it goes on, it produces critical limb ischemia, rest pain. Patient has pain right through whether he walks or not. This is the extreme stage, and the patient will have loss of sleep because of pain. And this is the time where, unless we intervene with the domains that we have, with the particular treatment schedule, which I am going to allude to you soon, and then it goes to a toe gangrene. The toe becomes black, and then that means it is a non-viable, it's not living anymore. Then there's a grave situation there, and which will progress to an ulceration in some time without any trauma. They'll say that it just came by its own because the cells have lost the blood supply, it just gives way. Then, of course, we have very, very extreme non-viable, which means the patient cannot stand on it, leave alone walk on it, work using it. Then, of course, what we find in testing, that there is obstruction, but towards the in the calf muscle and the leg vessels called tibial vessels and the feet, there are no vessels open, which means I think it's almost a very serious situation. Nothing much we can do, although we have some options, some temporary measure can be there, but nothing reconstructive we can give in such situations. Clinical examination involve, as you know, history. The patient tells you his symptoms, but unfortunately, only 50-60% of the patient will tell you the classic claudication. But they will say some pain in the joint, pain in the toes, pain in the foot, and all those things. And then that is very historically, that will put an idea that his legs blood supply may be reduced. Then, of course, examination is crucial. We have the femorals, popliteals, and anterior tibial, dorsalis pedis, and posterior tibial vessels, rarely peroneal. These can be felt methodically. If you have an equal pulse with an equal BP in the upper and lower limbs, that circulation is good, so it cannot be a vascular problem. So we can come to a diagnosis from history and physical examination in peripheral arterial system, like the peripheral artery disease patterns that we see. Now, how do we proceed further? History, listening to history, then physical examination is almost confirmative that there is a block at certain level. Then, of course, I just said the difference between upper limb and lower limb. Generally, it is if upper limb is about 120, lower limb will be 120, 130, not more than 140. Whereas if there is a difference of say 20 millimeter of mercury between upper and lower limb, that means there's some block, some hold up in the aorta and the iliac arteries. Duplex scan is a critical investigation. It tells us the type of the obstruction, level of obstruction, the extent of obstruction, whether there's calcification, and of course the distal or not. Distal vessels, lower down the vessels are open or not. Transcranial Doppler is basically done for head, the middle cerebral flow, so that we can make out the status of the brain circulation. Then, of course, the ultimately the confirming investigation is contrast enhanced CT scan. But however, this is not for diagnosis. This is done to have confirmed diagnosis with duplex clinical examination, and patient requires treatment, intervention for a sick leg to improve the vascularity. Then only we do the contrast CT. That is to make sure the blood vessels are seen, obstructions are seen, stenosis is measured, etc. Then, of course, MR is usually not that significantly used in vascular surgery. Then, of course, it's very important the vascular surgeon, cardiologist possible, certainly the interventional radiologist, we should have a discussion about the patient's situation, investigation results. Then I think we call it a patient-centric decision. What patient requires is only medical management or intervention like angioplasty stenting, or if he requires any other treatment like open vascular surgery, if anything is not possible at all. We do still some fine patients come where nothing actively we can do. Quit smoking, control of diabetes, hypertension mandatory. Diet discipline, I already mentioned. I think after about 40, 45 years, we need not eat too much. We just have to eat half of what we used to as a child or adolescent or a young person. Physical activity is mandatory so that you don't get the starch converted to cholesterol and get into trouble. Management options. By now, you would have realized that it is lifestyle modification, graded walking. That we tell them to walk every day, morning and evening if possible. Otherwise, you can use a cross trainer or a treadmill so that you do some walking exercise to burn off your calories. Then, of course, medications are statins to reduce the cholesterol level, ecosprin or cholesterol to make the blood a little thin, and then of course the specific medications are there for improving vascular this thing you call the trendal pendoxyphylline or phosphodiesterase, that is we call it stilose. These are supposed to increase the blood circulation. So these three together will be useful in addition to the lifestyle modification. Then of course endovascular intervention. You can use plain angioplasty, or the plaque is not opening up or the plaque is collapsing. So we can use a stent, it's a nitinol stent to open up the artery satisfactorily. Aneurysms, of course, that's not the topic. We can do endovascular repair as well. Then, of course, open surgery called bypass grafting for the lower limbs. So these are the drugs which I alluded to. Now, percutaneous balloon angioplasty is a standalone treatment. If necessary, we have to do stenting. We can do a bypass surgery. Lower limb mostly we use, if it is starting from the groin, infrainguinal, we use a great saphenous vein or a short saphenous vein or a cephalic vein. Or if aorta is involved, it's always a Dacron or Gore-Tex graft that we use to reconstruct. Then the hybrid procedure is when we can use, stenting or percutaneous angioplasty for ilia and do a femoropopliteal graft so that we don't open the abdomen. It's a combined hybrid procedure that will help the patient. Few cases I will explain to you. 60-year-old, lower limb, no pulses, and he had intractable lower limb pain for 1.5 months, ulcer in grade 2, not slept for many days. And that is the picture. I think the first top arrow shows the common aortic bifurcation is only committing to the right common iliac and right leg. Left leg, that right common iliac and external iliac, all are blocked. Then down here, again, the superficial femoral artery and popliteals are blocked. He came on a wheelchair and he was looking, the leg was looking very critically involved, and I was myself a little concerned, but I told him I will not restrict and do the needful. We did an aorta to profundoplasty, and that is the procedure, Dacron graft from infrarenal aorta, that's being sutured, and that's the plaque removed. and then this comes into the femoral artery. And then now he has got a 70% angle brachial index, and he is very happy, walks 2 kilometers. If in case he needed anything, I thought I will do the femoropopliteal block, I think, but then he is not required. So 0.7 is the angle brachial index. This is a patient who has not slept for a week. One of the our receptionist husband, he's been a smoker, that has vitiated his problem further. You can see there's a gap in the artery. Actually, it starts from the groin down, and then that is the bypass we have done. I don't know from you can make out the movement of the saphenous vein. You can see in the middle that blood is passing. It's a big incision, but he is doing well now. About 1.5 years, he's about to walk more than a kilometer. Otherwise, he was having rest pain, could not even walk even 3-4 feet and in his house. You can see that vein is pulsating. Now, we come to the stenting and angioplasty. You can see that it is narrowed down to about 20% of the lumen. We call it inner side where blood is flowing. And if you compare with the lower one, I think this is such a small lesion. It can be opened up with a stent and after angioplasty. You can see that good flow is there. Then another case study, intractable pain again. This patient had a problem with the second time fixing the fracture, and then I think they got into the femoral artery, they ligated sent for management with us, and then we did a CT angiogram. It showed artery is blocked, of course. Popliteal artery was not filling. Then we have done opened the artery without any clamp. It was clot there, and that is the vein graft. We have gone to the popliteal artery. That's the clot formation which we have removed and bypassed. And this lady is doing well. It's about past 2 years. This is the Doppler study. And there's another patient, 86-year-old man, came after 3 days of getting pain. And you see that green arrow shows a gap. And then I had literally some confusion whether it's a embolus from the heart or an 86-year-old man or an atherosclerotic disease which is acutely transferred into a ruptured plaque. Only point was 2 pointers. One, he has a pacemaker implanted and a rhythm problem, number one. Number two, he was walking almost 1 or 2 furlongs for 86-year-old man. It's not bad. He had an excruciating acute pain and he almost collapsed in his house. That history, something sudden. And then what we have done, this clot from the external iliac artery, common femoral artery, SFA, popliteal artery, and the tibials. First time in my life I've seen such a big clot occupying the whole this thing. He's developed some Alzheimer's, which was there earlier, which is worsened, but he is still able to walk on his feet. This patient has got a small lesion there and angioplasty and stenting done. Pulses have improved. This you can see that this tip of the great toe, what we call is early gangrene, and if we don't treat, he will get into trouble. And here he had a popliteal occlusion, and we have dilated. 58-year-old man, you can see the gap between the after common iliac artery to femoral artery. There is a big gap, and he underwent angioplasty first, but he had a rupture of the artery, and I had to, in the midnight, I had to give him a graft, and that is the iotobiform graft he is given. Then this is a patient, a small aneurysm. It's only some 3.5 centimeter, and he came in a wheelchair with suffused feet and severe pain, and he could not walk at all, hardly 4 or 5 feet at home. You can see that iotogram, color iotogram. You can see the left side, common iliac, external iliac, internal iliac, all are missing. On the right side, it's a shorter block, but he was suffering from continuous pain. Intractable rest pain, we call it. And this is what I did, connected a thoracic aorta to the femoral arteries with a after thoracotomy and a retroperitoneal dissection. And now it's about 2017 I had done. He's very happy walking as much as he needs now. Now, in summary, the current vascular endovascular strategies, the understanding, the treatment schedules are saving limbs, lives, and organs. And best medical management is a common factor. We do angioplasty or stenting, but once you do stenting, you have to continue more. If it is open surgery, to a lesser extent. And prevention has a great role to keep the bipedal gait and quality of life. This one X-ray, I mean CT scan, if you see a lot of collaterals. He came to tell me that he could walk only 2 furlongs, 3 furlongs. He was walking 2, 3 kilometers. But then I put him on medical management. Lot of collaterals were there. And now he has come back to 1 kilometer. He did not need any intervention. Sometimes keeping your hands folded behind, not to intervene when it's not required, is also an important decision. This again another patient. Between those two arrows, it's about 30 centimeter occluded SFA, but good collaterals, and you don't have to intervene and knock out all the collaterals. And unnecessarily, when you do surgery, there's a tendency to get the graft thrombosed as well. Now, one word about non-reconstructable. We, out of 10, one patient in extreme ages because of prolonged history and they did not attend, they thought it is, in Malayalam we call it vadam, that means some joint pains and all that, they come, no runoff, we cannot do any reconstruction. We have two options. We can start him on heparin, then put him on prostaglandin for 5 days a month. Then I think we have avoided amputation in many patients. Stem cell therapy is a newer version, the vascular genesis, so that the vessels are come up and then the vascularity increases. Now, we have a campaign in Kerala. VASC is the Vascular Society of Kerala, and Governor inaugurated that. Now, that was about 2 years back. Now we have it gone to the amputation-free India, and this year our slogan was amputation-free globe. So many Society of Vascular Surgery, so many other European, American, they are very happy that we have got a propaganda to avoid and to make people aware about our role in preventing amputation. I think our combined work has made a good difference and saved, even for the last 2 months, I would have saved 3, 4 patients from a sure amputation with our, whenever we needed angioplasty stenting or open surgery. Now, we've had the National Vascular Day on August 6th. You can see the 28 cities all across India. And of course, this year also we are planning. We have had it 2024. We had the same campaign as the at a national level. Then it has gone even beyond, because there's a one good thing. If you cannot reach a place where you want to, I think your life is limited. Your quality of life is also gone. So now, take home message, I would say, 3 common domains of arterial disease because of atherosclerosis occurs in peripheral arteries, coronary arteries, and carotid. They will be evolving into, not to the same extent. They may present with one vascular bed problem, but you should be aware these 3 have to be investigated. The risk factor control, graded walking exercise, and triple vascular therapy, very effective, and it can be limb saving in many cases. And no intervention we do for claudicators. That means somebody can walk 200 meters or above. There's no need to do any surgery or standing. Medical management and risk factor control. And intervention is exclusively kept for critical limb ischemia, because in critical limb ischemia, there's a real danger of losing the life, whether it's angioplasty. Angioplasty we may use for improving the quality of, supposing there's a vendor, somebody has to walk to 1 or 2 kilometers, suddenly he cannot walk, say, only 1 furlong. It comes into his livelihood. Young patient, 40, 45, we may go for angioplasty. But angioplasty, a little more lower threshold for intervention, but for open surgery, absolutely, it is critical limb ischemia. So that's our hospital. It is the King's Palace, and partly a newer building of 7-story building. We have a good teamwork here with the radiologist, cardiologist, and myself, and we are able to help many, many patients. So I'm happy and I'm grateful to Clarinet and Sion as well as Angana for giving me this opportunity to talk to you. And thank you very much for listening as well. I can take some questions if you have. Thank you.
Thank you so much, sir. We do have some question from our
Okay.
audience. So, sir, the first question from our audience is: what are the outcomes and complication associated with endovascular treatment of PAD?
Yeah. See, there are, you have to define what you are going to do. Generally, they say that common iliac artery occlusion or stenosis you can dilate. And when, say, for example, the thigh vessel, when it is 10 centimeter, maybe 10 to 12 centimeter or less, you can dilate. So in that cases, I think I would say it is going to be technical success of 97%. Then further improvement, further keeping that revascularized status, it depends upon the patient by gradual walking, taking care of diabetes and control hypertension and no smoking. The smoking produces a lot of problem. The lower arterioles and small vessels will occlude, will go into spasm, and then there will be recurrence, and it's very difficult to this thing. But then, having said that, when you are more experienced, you may try instead of 12 centimeter, maybe 20 centimeter, 25. And the moment we put a stent in the thigh, there are so many, some 20 types of stents are there, but none is foolproof. And they all eventually, sooner than later, after 1 or 2 years, they got. So, stent thrombosis is one. Now we have vascular medical support like rivaroxaban, that is the Xarelto. We have a lower dose instead of 50 milligrams BD and a 20 milligrams OD for 6 months. We have 2.5 milligrams along with either single antiplatelets of ecosprin or clopidogrel. That can keep the graft open, stent open, and avoid thrombosis, which is the final event. So I would say, and then there can be perforation. And I think it is the question of selecting the right patient and doing the right thing. It's not that I do what all things I know for a patient. It should be what patient and his lesion dictates. So if in that case, I think I would say it's a 95 upward technical success in most of these things, provided the distal runoff is good.
So, there's one last question: how promising is gene therapy in the treatment of PAD?
Gene therapy, first I heard the specialist from Liverpool, I forget her name, she was talking in 2002 in Singapore. Now also they are talking. That's all I know.
Thank you so much, sir, for answering all our question. And just to correct you, sir, we are from IGCP, not Learned.
Is it? Okay, okay.
Thank you so much, sir, for joining us today. Before concluding, sir, any last message from your end or take home message?
No, I think what my feeling is you should have limited amount of diet and at least limited amount of exercise. That is number one. Number two, if you can walk a mile, you can live with a smile. If you can walk 1 mile, that is 1.6 kilometers, I think your health status is good, your systems are good, your arteries are good, your heart is good. So I think that's the way to go.
Thank you so much, sir, for joining us today. With your permission, sir, I would like to conclude today's session.
Yeah,
Thank you.
give me a note from including your facility, what it is. I'm confused because I'm asked to give talk some 2, 3 people. I enjoy this because that's what I enjoy doing, helping patients,
Sure, sir.
and that's what when I passed my school, I wanted to become an engineer. So my father said, "No, you become a doctor, you can help people," and I'm absolutely incredible feeling that we are able to help. Whoever needs our help. So I think it's very happy that I have become a doctor. I have become a vascular surgeon.